First, I'm Dr.Udya Rodrigo, a consultant intensivist at Rodrigo Hospital. I'm going to take you through an interesting case scenario. This was a real case managed in a well-resourced setting. Our patient was a 55-year-old man who was admitted to a surgical ward. He had complained of right-sided back pain along with abdominal pain going on for 2 days with fever and few episodes of vomiting. So he had a background history of diabetes, hypertension, and who had been treated for renal colic on the previous year. So the examination findings briefly was febrile, tachycardic, and the blood pressure was reasonably under normal range, and it was little moderately tachypneic, and also on examination of the abdomen revealed there is a tenderness on the right flank. So as per the initial ward management, the basic investigations, including the full blood count and the cultures, have been performed, and he has been started on the basic management like IV fluids and first-line antibiotics as co-1 square, along with other symptomatic medications started for his symptoms. And I've commenced plotting his vital parameters on this chart. I hope that some of you all might have seen this early warning score chart. When you chart his vital parameters, the heart rate around 100, the respiratory rate 20, and the saturation and the temperature, all that. So his total score coming to 3. So that is not very significant to alert. And then his investigations revealed he had a neutrophy and leukocytosis with predominant neutrophils and with reasonably normal CRP level, the normal range was up to 5, and the normal creatinine and the rest of the investigations was initially normal. After about 3 hours of admission, his parameters changed. He became hypotensive with a mean arterial pressure of 50, became more tachycardic, and he became even more febrile with a temperature of 39 centigrade and tachypneic with a respiratory rate 30. And now he required oxygen to maintain the oxygen level. And also they noted his urine output was gradually tailing off. So based on the second 3-hour vital parameters, we plotted these parameters on the same chart, early warning score chart. So according to this chart and the color code, the different scoring was given, so you might not be able to see it properly. So the total score now came to 10. So what is the diagnosis? What do you think of the diagnosis? So I now call upon Dr. Wijesuriya to proceed the rest of the talk. No, I don't think that they are very sure about the diagnosis. Tentative, yes. Anybody? Surgeons, not surgeons. Anybody? Yeah, thank you. Right, so the diagnosis was sepsis, and I'll see what this sepsis is about. So the definition of sepsis comes from the third international consensus definition for sepsis and septic shock. This is sepsis 3. We don't want to go through all the definitions we had in the past. They were very cumbersome to remember, and we don't need them because now the definition has changed in 2016. life-threatening organ dysfunction caused by dysregulated host response. So it's quite short and easy to remember. You have to remember only two things. One is sepsis, the other one is septic shock. So all these severe sepsis, multi-organ, all these definitions which we had in the past have gone. Now it's easy to remember, easy to diagnose. So septic shock is a subset of sepsis where persisting hypotension requiring vasopressors to maintain a MAP of more than equal or more than 65 millimeters mercury, and blood lactate more than 2 millimoles per liter despite adequate volume resuscitation, and it causes increased mortality. So what is the scale of the problem of sepsis? It's a massive problem where a huge number of deaths, and it costs a lot because all this expensive intensive care and antibiotics and the vasopressors, they all come to very high cost. And unacceptably, the mortality rates throughout the globe is quite unacceptable. So if you look at the global range, if you look at United States, where we assume that health care is very advanced, I think we got wrong message up to now. After COVID, we have realized it's not so. So the mortality rates are 28 to 50%. And in Europe, it's about 20 to 80%, depending on the country. The better rates are available in Scandinavian countries. And in Australia, it's about 18,000 deaths per year. And in Sri Lanka, of course, we don't have any published data. So there was a prospective cohort study which was carried out in 16 Asian countries where the hospital mortality rate was about 44%, 0.5%. So it's quite tallying with the other countries. So why is this mortality rate high, you think? Is because the awareness of the seriousness remains low among the public and among the doctors as well. And this sepsis, when it is very severe, it's very frequently underdiagnosed at an early stage where it is still potentially reversible. So the problem happens when the sepsis becomes uncontrolled and it becomes irreversible, and the changes are irreversible. So you need to remember this slide. If you don't remember anything else, please remember this slide from the whole symposium that we are having today. Recognize, resuscitate, and refer. So this is the mainstay of the whole concept, because sepsis kills. So if you look at the mortality rates, sepsis has a mortality of more than 10% if it is just sepsis, and if it is septic shock, the mortality rate goes more than 40%. So why is it difficult to spot? Because the sepsis can come in various presentations, number of phases, and in some cases it's very obvious. Now in this patient, I think it was quite obvious that he is septic, right? Because he's having some symptoms of sepsis like hypotension, fever, but in some cases it's not very obvious, especially small babies or elderly people. It's just non-specific, because if you look at this chart that Dr. Udya Rodrigo was talking, the parameters, the basic parameters that we put on the chart, they may go up. If you run fast, your heart rate will go up, your respiratory rate will go up. So they may be non-specific. I'm just giving a very crude example, but any other illness can also cause tachycardia and tachypnea. So they are not very specific. So as I said earlier, early recognition is very important because the condition is potentially reversible if you don't allow it to proceed. So to help the clinician to come to a diagnosis, a possible diagnosis, the problem is this: as it comes to sepsis, is actually nobody's child, right? So it can present to any ward. Therefore, there's no specific consultant or a specialty which takes care of sepsis, because it can be in the neurology ward or the medical ward, surgical ward, gynecology, everywhere. So therefore, it's very difficult. So we must have some way of recognizing. Especially, we thought of giving you more insight because this is a general sort of mixture of all clinicians here. So how do we recognize that a patient is having sepsis or septic shock?
So the bedside screening is very important. There are very few things that you have to remember today for the general clinician. So it should be simple and quick, and should be able to do it in the emergency department or in a ward, and outside the critical care units, where you will detect these patients as the first encounter. So if you remember this magic hat, so I want you to remember that sepsis kills the bomb and the hat. So this is the magic hat, because there is something called quick SOFA. The score of identifying screening is Q SOFA, that is quick SOFA. So SOFA is the respiratory rate more than 22, altered menstrual status, and the systolic blood pressure less than 100 millimeter mercury. So the hat, when you remember the hat, H is for hypotension, that is despite fluid resuscitation, they will have a sepsis, that is septic shock. This systolic blood pressure less than 100. A is for altered consciousness and T is for tachypnea. So the three things that we look at in this scoring system, it is easy to remember by remembering the magic hat. So this predicts mortality. So if the score is more than 2, the prediction is the mortality rate is about 10%, but it's generally about less than 10%. If the patient goes into septic shock, then it goes about 40%. So if you look at the risk prediction, the altered mental status, tachypnea and hypotension. So it is HAT. It's not in that order here. So the risk is increasing with the number of systems and organs involved. So the 2 to 3 points or 2 more than 2, the risk increases. And the outcome will be poor. So the importance of early detection, I don't have to stress again and again, because if you just recognize sepsis, it's not going to be enough. So we need to early detect and remember to start managing these patients, resuscitate them early. Because the critical aspect of mortality reduction is to identify it as early, because there is something called time zero. We will talk about it a little later. Because the clock starts ticking as soon as the patient gets septic. So if you delay, the outcome will be poor. So because it's a time sensitive disease, and all the points of, we have so many guidelines, protocols, but all this will be not valid. There's no point of giving very expensive hi-fi antibiotics if you have not detected it early and treated it early, because the organs will go into failure and they will be irreversible. So, Dr. Udya Rodrigo was talking about this national early warning score system, uh, which in Sri Lanka we just talk about it. I don't think we have these charts available in the government hospitals, but in private sector, some of the hospitals have them. So it has a sensitivity of more than 79% for detection of sepsis, apart from the SOFA score which I talked about. So SOFA score is much more easier for the general clinicians to remember, right? So just only three things: hat, the magic hat. You can remember that easily. So here we chart, or we have a chart where we will, this is the chart that she was talking about. It's color coded. So when you put the dots on the chart, if it is in the red zone, we know it's dangerous. And when you add all the parameters up, depending on the score, you have a response. So for sepsis also, you can use this to detect the severity of sepsis. And the important thing of this chart is that we use very basic parameters. We don't need anything, any hi-fi gadgets. So things like respiratory rate, conscious level, blood pressure, pulse rate. These are all basic things that we always measure in our patients. So what we clinically see in a septic patient, that they have multi-organ dysfunction, right? So in lungs, you might see ARDS, cardiovascular, there will be refractory hypotension, and we see a lot of patients on noradrenaline on the wards now because we have limited number of ICU beds. So kidneys, they can go into renal failure, acute liver failure, and they can get altered conscious level and DIC and clotting and bleeding disorders. So I think I'll hand over to Dr. Anushka Mudalige, who is our consultant intensivist, to talk to you about the rest of the things. What are we going to do once we have detected, and how are we going to manage the patient rest of?
Thank you, madam. So, moving on from actually moving on to when to diagnose a sepsis. What is this time zero? The time of triage at the ED or if presenting from the ward is the earliest point. All elements of sepsis are certain through chart review. So this is the next few slides. I'll be talking about what is this importance of determining the correct timing of confirming the sepsis. So it's a balancing art, we can say, because you can overestimate sepsis or you can underestimate, but you don't want to do either. You want to catch them just when they get the sepsis. Because the problems are like if you overestimate sepsis and start treating, that will stop the sepsis from progressing and your sepsis, the actual values, the logistics will get altered. You no longer will continue to diagnosis. On the other hand, if you undertreat it, the patient will go into septic shock and then end up with increased mortality. So you have to balance that to actually catch the septic at the correct time. So we need a screening. In order to do this correctly, we need a screening program. So, routine screening of potentially infected, seriously ill patients for sepsis to allow early implementation of their therapy. So that's what we say. In the ward setup, but if we can, if we think that this patient has a potential going to sepsis due to some reason, some risk factors, you can actually start the early warning scoring system and then catch them at the correct time. So this, I'm afraid, has to come from a national level, not just at our ward. We can't just implement it in a ward setup. We have to start it from the ministry level, then at the hospital level, the direct level, and then it has to come down to the wards setup. So we that the whole country starts implementing this. So then also there are a team called Outreach. Unfortunately, again, we don't have like outreach kind of, but we have a emergency response team, but we need an outreach. So a specialized team who are trained in responding to patients with sepsis, catch them early and then treat them at the ward setting itself. This would actually help in reducing the ICU admissions. So that is also one of the methods to cost methods of screening. So as I said, then there's a team approach. Sepsis cannot be managed by one person alone. As Madam said, it's not one person's baby, but it has to be have a multidisciplinary approach. The microbiologists, the surgeons, the physicians, and the radiologists all will get involved. And we already spoke about the news chart and outreach. So all this is needed in order to fight sepsis correctly. So the challenges are in identifying sepsis are the symptoms. As Madam said, they are subtle. You might miss it in the ED, the triage, or at any point you can miss it. And these symptoms can actually mimic other potential less serious conditions. On the other hand, it can the condition can escalate very drastically, and the patient can deteriorate. And nobody owns sepsis, as we said. Any of you can come across a patient. And we have limited sepsis identification and management resources. So these are the problems of managing challenging sepsis. So what's next? So we have now come through the diagnosis, how the presentation, the diagnosis, and so next we will go on to management. So what is the management? Of course, this is, as we said, it's a severe life-threatening organ dysfunction that causes increased mortality. So in order to fight this disease, we need a very organized process that is very specific, that focuses and hits early. So that guideline is given to us by the Surviving Sepsis campaign. This campaign is a global initiative that was started in 2002. All the professional bodies worldwide got together and thought, so we have to do something about it. And they made a guideline based on this. By 2016, they say they were able to come down on the mortality by 25% just by implementing these guidelines. So we have the latest guidelines, surviving sepsis, updated in 2016, which I'm going to explain in the next few slides. You don't need intensive care to start treating sepsis because sepsis is a medical emergency. ICU beds are scarce. Wait until you get in bed, the patient is not going to survive. So you start this guideline, the bundle, then you monitor this patient. You can do this at both settings. So we call this guideline a bundle care. You can see each of those sticks is if you imagine that each of those sticks is an intervention, and you collect all those interventions and keep them together. They will lead to a better outcome compared to one stick alone. So that's a bundle care. So at time 0, that is the time of presentation, you diagnose the patient. Then you initiate the protocol. And as I said, it should not be delayed pending ICU beds. There are 2 bundles. The first is the resuscitation bundle. The second is the maintenance bundle. The resuscitation bundle should be started within the first hour. So there are 5 steps in the first bundle. 1 is measure the lactate level. If it's more than 2, you have to re-measure it with each intervention. 2, you have to take cultures, not just blood, but any culture. If you suspect where the focus is, you have to take the culture from that focus. And the culture should be taken prior to antibiotic administration. 3 is administer broad spectrum antibiotics within the first hour. You have to do this. 4, if the patient is hypotensive or the lactate is more than 4, you start fluid resuscitation. I'll talk about later in the next slide. And 5, while fluid resuscitation or after fluid resuscitation, you can start vasopressin in order to maintain your MAC of 65, that is the target MAC. So initial resuscitation, how much to give, what to give. The Surviving Sepsis campaign recommends a 30 ml per kg bolus to be given within 3 hours, grade 1B recommendation. And this 30 ml per kg can be a crystalloid is preferred. Which crystalloid? An isotonic crystalloid. What we have is Hartmann's and in some places plasmalide, because their tonicity matches our body's tonicity and it won't cause metabolic acidosis later on. But if that's not available, 0.9% sodium chloride. And now I have seen albumin being misused a lot everywhere, but in this case, there is a place for albumin. 4% albumin can be included in that 30 ml per kg bolus as a colloid. Starches are not recommended, they are actually contraindicated due to their adverse effects of bleeding as well as allergies. So these are the 2 fluids that you can keep, isotonic crystalloids and albumin, 30 ml per kg. You don't have to give 30 ml if the patient is now stabilized. You can stop in the middle, but the maximum they have recommended is 30 ml. Then antibiotic therapy should be, as I said, started within the first hour. Hit early and hit hard is the principle. So that is, and you have to take cultures before you give the antibiotics. So within the first hour, a very strong antibiotic. Interesting graph. The pink bar shows mortality. So and the x-axis shows time. The more the time that is spent without doing the interventions, the higher the mortality. At 36 hours, it reaches 100%. So if you just leave a septic patient, in 1.5 days, the patient should die. On the other hand, if you treat the patient within the first 0 hours, the survival is 80%. Still 20% will die, but survival is, that is with fluid and the antibiotics. So timing of blood culture, of blood collection, the problem, if you give antibiotics before the culture, even with one dose, they say the blood gets stabilized. So in order to catch that bug, you have to take the cultures before giving the antibiotic. So ideally, it should be taken from 2 places and 2 sets, one for aerobic and one for anaerobic. And if the patient is on a central venous catheter or some sort of vascular access device, if it was inserted more than 48 hours ago, you have to take a blood culture from that as well. So I hope that's clear. So you need 2 blood cultures from 2 places and aerobic and anaerobic. So altogether 4 ideally. So other samples, if there is a collection at any part of the body, you have to take a culture from that. Pleural effusions or ascites or any peritoneal aspirates, urine if the patient is sputum, if intubated, tracheal, if the patient is on an external ventricular release CSF or urine, yes. So any collection and surgical sites, if they are infected, from there you have to take the culture. And the initial antibiotic, as it says, hit hard. Broad spectrum therapy is initiated. So the most likely pathogen is based on the local epidemiology and the criteria, but try to cover most of the microbes that are potential pathogens. Also, depending on the patient, you might add an antifungal in the current situation and antiviral. Now, while giving fluids or after giving fluids, still if your MAP does not come up to 65, you have to start a vasopressor. So our first choice, according to this campaign, is noradrenaline. And that is the maximum dose that you can go up to. And if noradrenaline doesn't work, second choice is either vasopressin or adrenaline. You can see whether the patient is adequately vasoconstricted, because the problem with sepsis is profound vasodilatation. So you have to get that vessel constricted again. You might go in for vasopressin, again the maximum dose is given there, and or adrenaline, which has an inotropic effect as well. Now, sepsis causes a cardiac dysfunction also. If you get that in your echo, then there is evidence of cardiac dysfunction, you can go for dopamine as well. There's no place for dopamine in sepsis. Now, after the initial fluid resuscitation, further fluid should be based on your assessment, because there is a fluid deprivation at the initial point, but later on, after 1 or 2 days, they're going to fluid overload if you just keep on giving fluid. So you have to assess their fluid status after the patient has been resuscitated. This is after fluid sterilization. So we use in our ICUs various methods to assess the fluid, which are kind of difficult in the ward setup, but I'm just telling you for completeness sake, you have to assess fluid and give after initial resuscitation. So in your setup, what you can do is clinically evaluate after fluid bolus, recheck the blood pressure, heart rate, the saturation, the respiratory rate, or you can, if you are using a chart, you can review the chart and see whether there are any improvements in your parameters. Now, what are the goals? Now, in the year 2000, there was a scientist, Rivers, who did a trial on septic patients, and he showed if you got those targets that are shown on the screen there, within the first 6 hours, by giving fluids and by using vasoactive agents, the mortality reduces by 60%. So after that point, after the year 2000, we've been following these targets. But then later on, in the 2015s, 18s, there were more trials which were more powered, and they showed you don't actually have to go for these targets because even if you do get them or not, despite whether you achieve them or not, the mortality is the same. But the advantage of having these targets is then you can actually you have a target. Otherwise, you are just you don't know when to stop or whether to give more fluids or what is you don't know where to your target actually. So you can, as a rough guide, you have you can always measure the MAP. You can always measure the urine output. If you have a central line, you can go for that CVP target. And if you have a central line, you can measure the superior vena cava oxygen saturation. That you take, that is, you take a blood sample from the central venous catheter and do a blood gas. But just for fluid resuscitation, you do not need to insert a central line. I hope that's clear to you. If you have a line, you can do this. Otherwise, you can go with the MAP and the urine output. Then the other one is source control. So no matter what you do, as long as there is a source, you will not control the sepsis. So in order to find the source, you might have to do certain types of imaging. So along with resuscitation, you have to go for this imaging as well. And at the same time, if you find an abscess or if you find necrotic tissue or an infected device, a line and maybe a valve, cardiac valve, you have to remove those immediately. And the procedure to remove that infected source should be minimally invasive as much as possible. General anesthetic to a patient who's already compromised is not going to end well there. So minimally invasive, like a percutaneous drainage system under radiological guidance, is preferred over surgical or open surgery as much as possible. And remove all the lines. If there's a catheter, remove it, intravenous devices. If you think that is the source, you have to remove that as well. Source control. So, in a nutshell, we have all that have mentioned already. So this you can take as the maintenance bundle as well. We give fluids, we give antibiotics, we start vasopressors, and we start enteral feeding. The moment the patient is resuscitated, the first thing we do is we stop the IV fluid and we start on enteral feeding, which is very, very important. So we can start this even on day 0 as well. And also we start insulin to control the sugar. And if the patient goes into ARDS and we have to ventilate, we do something called lung ventilation. Again, the maintenance bundle, we manage ARDS. This is all in the ICU until the ward setup. We sedate them if they are intubated. We give them analgesia. We might use muscle relaxants. And if they go into acute kidney injury, which need warrants renal replacement therapy, we do intermittent hemodialysis or continuous renal replacement therapy depending on the patient's clinical stability. We give stress ulcer prophylaxis because patients who are critically ill are more prone to have ulcers. And glycemic control, we go for this 140 to 180 target, not a tight control. And all critically ill patients are at high risk of developing DVT. So we start DVT prophylaxis. And nutrition, as I said, we start very, very early. So along with all these early protocol-based diagnostic therapy and multidisciplinary approach, as I mentioned, we can sometimes achieve success. And so back to our patient, the clock is ticking and we will take over. Yes, our clock is ticking. Clock was ticking. Yeah. I hope you remember the patient whom we initiated, the management. What was the early warning score we calculated? It was 10, if I'm not mistaken. Right. So, as per the ward protocol, this patient was started on the fluid resuscitation, and the initial blood gas revealed there is a severe metabolic and lactic acidosis. And then they informed the outreach team, and with the input of the critical care consultants, patient was managed afterwards. And according to the
Surviving sepsis protocol guidelines, patient was given the fluid resuscitation, boluses up to 30 ml per kg. And then despite giving this much of fluid, patient remained hypertensive. So what's the diagnosis now? Patient was initially septic and now going into septic shock. And now this patient required oxygen for maintaining the oxygenation. Now this patient was shifted to the ITU. On admission to the ITU, our ABCD parameters, the patient was maintained oxygenation with hypooxygen up to 80%, FiO2, and on the breathing examination, it detected bilateral crepitations, and then he required escalation of the oxygenation therapy to CPAP, non-invasive CPAP. And in the circulation parameters, he became even more hypertensive with a map of 50s, more tachycardic with reduced peripheral circulation. And all the cultures and all the basic investigation repeated at that point, and along with the cardiologic examination, ECG, bedside echo, and troponin were done. And the antibiotic therapy we upgraded to therapy. That's usually happening in the managing these kind of patients. Since patient is in the intensive care, they inserted the regulatory line for vital monitoring, and the repeat blood gas revealed even more worsening lactate level and worsening metabolic acidosis. And now patient required suppressive support for maintaining the mean arterial pressure. So patient required invasive CVP line insertion, and then they started noradrenaline to maintain the target. And the urine output and other basic monitoring continued. And in the disability part, patient became now a little disoriented, and the random blood sugar level shot up to more than 12 millimoles per liter, which required insulin therapy to achieve the target 4 to 10 millimoles per liter. And his abdominal examination revealed bursting tenderness, and the ultrasound revealed this picture. What's that? It's not very clear. Any idea? So it shows there is a hydronephrosis, bursting hydronephrosis, as well as evidence of pyelonephritis. So this patient now had a percutaneous drainage insertion done for the draining of the abscess, and also nephrostomy for decompression of the hydronephrosis. And the sample sent for investigation. So at the end of the procedure, patient was further deteriorated, leading to multi-organ failure, worsening metabolic acidosis, and his X-ray appeared like this. What is that? Now this patient is going into ARDS. So we require invasive ventilation now. And as per the rest of the surviving sepsis guidelines, patient's vasopressor support escalated, requiring the second vasopressor support as the vasopressor. And since this patient had an arterial line, we started doing the cardiac output monitoring. That cardiac output monitoring revealed stroke volume variation of 8%. So up to 12% in an invasive ventilated patient we consider as normal cardiac output, but his systemic vascular resistance came as 750. So that is actually the normal value comes to around 900 to 1200 range. That is little low value. So that's why patient required the second vasopressor support, vasopressin infusion. And when we add the second vasopressor, we consider adding a steroid cover just to compensate the sepsis-induced adrenal dysfunction. So hydrocortisone infusion was added, and the transfer acid echo revealed global sepsis-induced cardiac dysfunction, which required anatropic support and the doctor was needed. And the further clinical picture worsened and patient was going into multi-organ failure, including the injury, which required renal replacement therapy. As there was no improvement for all these measures, they did a repeat scan which revealed there's a corticomedullary abscess with extension into the perimetric space. And then surgical debridement planned. So during the surgery, due to the extensive necrosis, they ended up doing an nephrectomy. So during the subsequent stay, the patient's clinical parameters improved, and the required patients of the rest of the ICU care was continued, and by about day 14 was extubated, and the renal functions were normalized. Did not require any renal replacement therapy, and so patient was completely well by after about 2 weeks. So this case scenario gives us some idea about early implementation of the sepsis guidelines can prevent serious outcomes such as death. And so somehow we prevented, this patient was saved by implementing all these measures. But maybe even earlier interventions, don't know whether we would have, that was able to prevent nephrectomy that happening in that patient. So it is again kind of a detrimental outcome in that kind of patient. So, but somehow the outcome was better in that patient. So we have almost come to the end of the presentation. You might be having various burning questions to ask from the speakers. So we will give you a time for that question and answering session. So what is this sepsis? Sepsis is a life-threatening medical condition which has a high mortality and morbidity worldwide. So it's a dynamic syndrome, and our knowledge on sepsis is still evolving. So, as a result, this definition and the management protocols are being changed time to time. So we need to update on those changes. So this is an effort to upgrade you about the latest guideline on sepsis. And with that, we have come to the end of this presentation. So sepsis, the summary of this presentation is we have to early recognize sepsis and early resuscitate, and with the input of the multidisciplinary team report, we can have a better outcome. So that is the take-home message. So may I now call upon the speakers and Dr. Dhananjaya, our microbiologist, to come to the table. So if you have any burning questions, you can ask from the speakers.